Um, Today I'm going to talk about general physical examination and clinical features in some of the common congenital heart diseases which you will be facing in the exam. First, we will be talking about the most common condition, atrial septal defect. So it's the most common congenital heart disease presenting with symptoms in adults, and the male-female ratio, as you all know, it's more common in females, ratio of 1:2. There are three types of atrial septal defect. I'm not going too much into theory. It's ostium secundum, which is the most common type of atrial septal defect. Then we have ostium primum, which is actually associated with cleft mitral valve in some cases, and sinus venosus atrial septal defect, which is the rarest type of atrial septal defect. Now, usually in atrial septal defect, you should know that the blood flows from the left atrium to the right atrium through the foramen ovale, and because of this increased volume overload towards the right side of the heart, there is progressive dilatation of the right side of the heart and the pulmonary artery, and later there is a tendency to develop pulmonary artery hypertension and shunt reversal, which means basically that the blood starts flowing from the right side of the heart to the left side of the heart. Okay. Now, this is a picture showing the atrial septal defect. Here you can see we have the atrial septum, and the blood flows from the left atrium to the right atrium, resulting in volume overload on the right side of the heart. And as this volume overload goes on chronically, the pulmonary artery finally develops hypertension, and that's when the blood flow starts reversing, and you finally actually start developing a reversal of shunt, and the blood starts going the other way, and that actually is called as the Eisenmenger syndrome. Eisenmenger syndrome. Okay. So here you can see the diagram of the atrial septal defect. This is the another diagram showing the positions of the various types of atrial septal defect. This is the commonest type, where you have the atrial septal defect in the middle of the septum, that is the ostium secundum defect. The next type is the ostium primum defect, where the defect is closer to the endocardial cushions, and sometimes that is associated with cleft mitral valve. And then you have the third type, which is the sinus venosus type, which is closer to the SVC origin. Now, coming to the clinical features, or the main part of the topic, in atrial septal defect, we should know that the symptoms in adults actually does not appear until quite prolonged, okay, until the patient reaches the fourth decade of life. So usually up till 40 years of age, the patient is asymptomatic. Just because it's a congenital heart disease, we don't need to believe that symptoms will be there from birth. Sometimes conditions like atrial septal defect, which comes under acyanotic congenital heart disease, the symptoms will start only at 40 years of age. So patient will have minimal symptoms like dyspnea on exertion, exertional palpitations because of the volume overload, and they can also have a history of recurrent respiratory tract infections in childhood. And palpitations can also occur in another way in atrial septal defect, because of the dilatation of the atria, they can develop atrial fibrillation, and that will cause palpitations at rest. Later, as the patient develops pulmonary artery hypertension, there can be right to left shunts, and patient can finally develop features of right heart failure beyond the fourth decade. Physical findings in atrial septal defect. One thing, when you get a congenital heart disease case in the exam, atrial septal defect patients might have a delicate gracile habitus, where the weight is more affected than the height, and we have to look for certain syndromic appearances. Especially, there are certain associations with atrial septal defect. One of the conditions is the Holt-Oram syndrome, where you have a hypoplastic left thumb or accessory phalanx, or a short radius, or sometimes even an absent radius. So we have to examine the upper limbs carefully, look for any absent radius or a short thumb or absent thumb. If you are hypoplastic thumb, if you see such a condition, you must think of Holt-Oram syndrome, and that the case might be an atrial septal defect case. The other two conditions which are syndromic and associated atrial septal defect include the trisomy 30 and the trisomy 18, which is the Patau and Edward syndrome. In trisomy 13, you have polydactyly, you can get flexion deformities of fingers, microcephaly, holoprosencephaly and cleft deformities with low set ears. Low set ears is usually when if you draw a line from the eye backwards, 1/3 of the pinna should be above that. If 1/3 of the pinna is below that, you actually, if the majority of the ear is below that line, you call it as low set ears. Trisomy 18, you have prominent occiput, low set ears, micrognatha and rocker bottom feet. And if you see a case of ASD and you're seeing that the patient is actually having cyanosis and clubbing, that means most probably that ASD patient has gone into reversal of shunt. There is a flow of blood from the right atrium to the left atrium, and that is patient has developed Eisenmenger syndrome. Okay. Next, in inspection and palpation, what you will get in a atrial septal defect cases, you can get features of volume overload of the right ventricle, where you will get prominent right ventricular impulses and palpable pulmonary artery pulsations. So, as you all know, when you are inspecting the right ventricular overload, features will be a left parasternal heave, which you can get by placing the ulnar border of the heart over the left sternum, and the palpable P2, where you take your finger and put it in the left second intercostal space, and you feel a faint impulse coming and just striking your finger. It is not a very strong impulse, and some patients have a systolic thrill. Auscultation. Now, auscultation is the main thing in atrial septal defect, where you have a mid systolic outflow murmur over the pulmonary artery area. So, the pulmonary artery area, if you auscultate, you will get a mid systolic murmur, and we have to focus on the second heart sound. Now, all of you know that the second heart sound we are going to auscultate in the pulmonary area and the aortic area mainly, and here we have to focus on the split. Okay, the second heart sound is split into two components, A2 and P2. You know that normally during inspiration, actually the split is more prominent. You have a A2 followed by a P2, and during expiration it becomes a single sound. Okay, that is a normal physiology. But in atrial septal defect, you will get a wide fixed split S2. Okay, wide fixed split S2. That is, you will be hearing the split A2 P2 during inspiration as well as during expiration, and whatever the position of the patient. Okay, now if you have any doubt, if the patient is sitting or if the patient is standing, the split should persist. If the split persists when the patient is sitting or standing, that means that is pathological, and that actually implies a wide fixed split S2. Now, one common question the examiners ask is, why is there a wide fixed split in S2 in ASD? Actually, it is wide because of the delay in the right ventricular ejection, because of the volume overload on the right side of the heart. It is fixed because the septal defect equalizes the atrial pressures on both sides throughout the respiratory cycle. So, that is one common question we get in atrial septal defect cases. So, if you are getting a wide fixed split S2 along with the systolic murmur in the pulmonary area, and your patient is actually around 30 to 40 years of age, and they have the symptoms suggestive of ASD, think of the condition as being a atrial septal defect. Some of the questions which you encounter in ASD patient cases, they might ask you what are the types of ASD, and as I have already said before, you can mention ostium primum defects, ostium secundum defects, sinus venosus defects. Then what are the syndromes associated with ASD? Like I told you, Holt-Oram syndrome, trisomy 13, trisomy 18, and features of Eisenmenger, which is the pulmonary artery hypertension, features of right heart failure once the patient goes into a reversal of shunt with cyanosis and clubbing. Next, I'll talk about the next cyanotic congenital heart disease, which is the ventricular septal defect. Now, ventricular septal defect is the hole in the ventricular septum, and the blood actually flows from the left ventricle to the right ventricle, and there is blood flows through the pulmonary artery towards the lungs. Now, the clinical features, ventricular septal defect patients usually they become symptomatic in childhood itself, and usually in the initial 4 to 6 weeks the patient might not have any symptoms. Later the infant develops tachypnea, prominent parasternal pulsations, indrawing of the lower ribs on inspiration, and when they finally develop pulmonary artery hypertension, reversal of shunt, they develop cyanosis and clubbing. Now, in adults actually, usually most of the patients who are having very small VSDs, we must remember that the symptoms will be very minimal. That is, there are some VSDs which are not hemodynamically very significant, but they will be having lot of signs on examination. Okay, so those patients actually, because of the very small amount of blood that is shunting, they are not affected much by it, they are not having much symptoms because of the ventricular septal defect. But when you go and examine the patient for inspection, palpation, auscultation, you may get lot of features, and that is because of the small size of the VSD. In VSD, the smaller the VSD, actually lot of prominent signs will come, but the patient is not very symptomatic. Okay, but as I said before, most of the symptomatic VSDs, the symptoms occur in infancy and childhood itself. Now, the classical feature is when you are auscultating the patient, you will actually hear a pansystolic murmur over the tricuspid area, that is in the third and fourth left intercostal space near the sternum, or in the tricuspid area you will hear a pansystolic murmur. Grade 4, because usually in VSD there will be an associated thrill, and usually that murmur can be heard all over the precordium, and small defect produces a very loud murmur that is called as Malady de Roger. Malady de Roger syndrome is a small muscular VSD with loud pansystolic murmur in the tricuspid area with a prominent thrill, no hemodynamic changes, normal ECG, and sometimes it can undergo spontaneous closure. So sometimes in exam you might get an elderly patient with a very loud murmur and a thrill over the tricuspid area. Then you have to think of a VSD. Patients may not be very symptomatic because these small VSDs don't actually cause much hemodynamic problems. Now, what are the common questions in VSD cases is, what are the other differentials for a VSD case? So, it actually is the differentials of pansystolic murmur in the tricuspid area. Here, you have tricuspid regurgitation as one of the differential diagnosis. The other differential diagnosis is mitral regurgitation murmur radiating from the mitral area. Now, the other question when you they'll ask is, what is the how do you differentiate a ventricular septal defect murmur from a tricuspid regurgitation murmur? Now, in VSD, actually, if you get a very prominent thrill in the tricuspid area on the lower left sternal border, along with your murmur, pansystolic murmur, most likely you're dealing with a ventricular septal defect case. In tricuspid regurgitation, usually there won't be thrill, and another feature is that on inspiration, deep inspiration, the murmur, that is right sided murmurs, increase with inspiration. So, when you are auscultating tricuspid area and you feel the murmurs increasing with inspiration and there is no thrill, you are more likely dealing with a tricuspid regurgitation rather than a VSD. The other question they ask is, how do you differentiate VSD versus MR? Again, ventricular septal defect murmur, it is loud and there will be associated thrill in the lower left sternal border. Mitral regurgitation murmur, actually, you will have the it will be more loud and having more intensity in the mitral area rather than the tricuspid area, and there will be radiation to the axilla or the lower left infrascapular area, that is the back. Okay, and usually in the tricuspid area you are not going to get a thrill in mitral regurgitation murmur. Okay, and another thing is, MR murmur actually usually is more best heard in expiratory phase of the patient, then that is the way you differentiate a VSD from a mitral regurgitation. Okay. Now, I will go to one of the cyanotic congenital heart disease cases, that is tetralogy of Fallot. It is unlikely that they will keep other cases in the exam. Now, the most important thing is, before you deal with the TOF case, you should know what are the four components. The four components of the TOF case are a VSD, ventricular septal defect, overriding of the aorta, that is the aorta overrides the septum, so that it almost acts like a common vessel for both the right ventricle and the left ventricle. Pulmonary infundibular stenosis, because of the overriding of the aorta, there is a pulmonary infundibular stenosis, and right ventricular hypertrophy. Now, here you can see the four components of the TOF, where you are actually having infundibular stenosis, where there is infundibular stenosis, where the pulmonary artery is actually stenosed, but it's not actually the pulmonary valve, it is usually a subvalvular stenosis more commonly. Then the second thing is a right ventricular hypertrophy, RVH, which you can see here, right ventricular hypertrophy. The third thing which you can see is a overriding of aorta, overriding aorta. And the fourth component, of course, the VSD. Okay, so these are the four components of the tetralogy of Fallot. Now, what is the pathology? The right ventricular outflow obstruction is the most common problem, and it's usually subvalvular. Very rarely only valvular or supravalvular, but most commonly it is subvalvular stenosis. VSD is usually a very large VSD, and as the right ventricular pressure increases, there is right to left shunt and cyanosis. Now, here you can see the problem in tetralogy of Fowler, that is, the right ventricle not only pumps blood into the pulmonary artery, it also pumps blood into the systemic circulation, that is into the aorta, and a mixed blood goes into the aorta from the right ventricle and the left ventricle, which is a mixture of both oxygenated and deoxygenated blood, resulting in the cyanosis. And the classical feature in TOF is the cyanotic spells, where whenever the patient develops fever or pain or sudden excitement, or in infants after feeding or after extensive crying, there is a increase in the stenotic right ventricular outflow obstruction. So when the right ventricular outflow obstruction in this area increases, actually more blood gets diverted towards the aortic region, and when it mixes with the left ventricular outflow blood, it becomes deoxygenated and oxygenated blood mixture, which actually results in the cyanosis. So the cyanosis can actually become severe, and the patient actually has to squat to relieve the cyanosis, and those are called as cyanotic spells, tet spells. Okay. So children usually they are cyanosed, more common in older children. Relief with squatting, and the one thing you have to remember is that the right ventricular outflow tract obstruction, that component is dynamic actually, and it increases when the patient after feeding or after crying spells or after fever or pain, and actually the patient sometimes may become unconscious and fall down once they develop a cyanotic spell. They may become apneic, that is called as fallow spells. So when you take the history, you would get the history of fallow spells or cyanotic spells from the mother. Okay. Now examination, patient will have stunted growth, and you will get cyanosis and clubbing. Some of the most severe cyanosis and clubbing you will see in cyanotic congenital heart disease. Patient will also have a polycythemic appearance along with the cyanosis. You can see that bluish tinge over the cheeks and the tongue as well as the fingers. And in very mild RVOT obstruction, right ventricular outflow obstruction, cyanosis may be absent. That is called as a acyanotic TOF. The cardiac examination, actually, when you examine in auscultation, the second heart sound will only be a single component. That is, only the A2 component will be prominent. The P2 component will be silent because of severe pulmonary stenosis, and you will get a loud ejection systolic murmur in the pulmonary area. This is the main feature of tetralogy of Fowler, along with the cyanosis, clubbing. If you get a single sound in the S2, no P2 component at all, and a loud ESM in the pulmonary area, you are dealing most likely with the tetralogy of Fowler. So the common questions are, what are the components of the tetralogy of the Fowler? That is, as I already told you, you have the ventricular septal defect, you have the overriding of the aorta, you have the VSD, and you have the pulmonary infundibular stenosis. And some of the shunt surgeries which are done in TOF patients, they might ask you as part of management, that you can say the modified Blalock Taussig shunt. Okay, thank you.